Good morning, and thank you for coming to our trauma grand round this morning. I'm just in the chair today. Before I introduce our speaker for this morning, can I just make one announcement just to remind you? We'll hopefully send out some flyers. The Royal Perth of the State Trauma Conference Symposium is on November, from the back, which date? What's the date? 29th November, and workshops. Thursday there are workshops, Friday and Saturday is the conference. So please keep them. Friday's the workshops, Saturday and Sunday is the conference. All right, so, and there'll be opportunity for free papers and posters as well. Okay, so we'll again just make sure that everyone speaks into the mic clearly because we're being recorded and there may be people online. So I'm going to introduce Dr. Delma Badenhorst. Delma is our current spinal fellow from Cape Town in South Africa. We heard about him because of his other innovative work in spinal trauma. Even before he came here, we heard about him about a year ago, so it's good to meet the man who's behind this new innovation. I gave him a fairly big list of things to talk about, so we'll see if we can cover that all today. And hopefully there'll be time for questions. All right, thank you and welcome to the Trauma Grand Round.
Thank you, Mr. Rao, for this opportunity. So this is a talk that I presented at the South African Congress 2 years ago because it was an upcoming topic because it became a medical legal issue in South Africa. We'll go into that a little deeper in the talk. So my disclosure stand. So this is Tygerberg Hospital. It's quite a big hospital in the sense that if you walk all the floors in that hospital, it adds up to 42 kilometers. There's a tumor unit over there. This is the academic building where all the medical students get teaching. Those are nurses' dwellings, and that over there is the mortuary. So Tygerberg serves a big population in the Western Cape. This is just the whole province of the Western Cape, which is that area down there. And a lot of patients from the Eastern Cape doesn't have any medical resources, so they travel towards the Western Cape, Tygerberg, and come for help. Even the ones from the Northern Cape, which is over there. The Northern Cape, I think, has only one spinal surgeon at the moment, and he needs to treat 2 million people. And so a lot of those patients don't get help, and they also travel to Cape Town for some medical help. So everything on the right side of that line comes to Tygerberg. So as just an introduction, there is a long-standing history of spinal reductions and spinal pathology dating back 4,000 years, even in the Egyptian era. And at that time it was deemed that if you have a spinal cord injury, that's it, nothing can be done. But in the wars, a lot of physicians struggled with how to manage spinal cord injuries, whether that was from a gunshot, shrapnel of a bomb, or something like that. And they realized then that if they did a early decompression, meaning removing the offending structure like a bullet or a shrapnel or a piece of bone, that those guys actually improved neurologically. And from that, a lot of studies, surgical studies, stem that if there is early intervention surgically, that there is a better prognosis for the patient. And a lot of these studies by these big guys actually confirms that if you have early intervention, decompressing a spinal cord, that the prognosis of those patients are improved. There were various animal studies that were done where they took a balloon in canines and they put it right next to the core. They inflate that balloon and they monitor the neurology. And then they, at different time periods, deflate that balloon. And they realized that, within an hour of releasing the balloon, the neurology recovers. And partial recovery was 3 to 6 hours. And if they were longer than 24 hours under that compression force, they didn't have any recovery. So in South Africa, we love our rugby, and I think this is the main stem of, one of the streams of injury patterns that we see, and especially in young patients that sustain cervical dislocations. In 2014, a 17-year-old rugby player had a game in the Swartland region in South Africa. He sustained a bifacet dislocation on the field. He was then transported to a nearby hospital in Malmesbury, who said that they don't have any spinal team or spinal guy that can look at this patient, and so they transferred him to another bigger hospital, who said the same. Then they transferred him to Cape Town at UCT, who had no capability of doing the closed reduction, and eventually he was then transported to Conradi Care, where Dennis Newton performed the reductions previously, and at that centre the reduction was performed. The problem with this, however, is that if you map this out, it'll take you an hour, maybe an hour and a half if there's traffic, to drive all the way down there. This boy was intact when he was injured. He had pins and needles in his fingers. By the time he arrived at the destination where he was supposed to be reduced, he was complete. So he was a quadriplegic. And so, therefore, in 2015, the Constitutional Court of South Africa made a ruling that all injuries need to be reduced within 4 hours of sustaining a cervical dislocation. Now, that had a huge impact on the public sector because we didn't have any plan on how to do this. The ambulance services take long. There's only one centre that does that in the whole Western Cape, maybe two. I think UCT also do them. And we had to look for answers. And so the first step in this is to do a review on what you actually have. So we looked at our traditional method of reduction, which is the one that Crutchfield described in 1955. And it's mainly inline reduction, where you would use a rope, a set of cones, calipers, a stack of weights, and a drip stand that's modified with a pulley. Now, there are various systems across the world that sort of build something that works to get this done. The issue with this is that it works, but it's only 73% accurate, and it can take up to 2 to 3 hours to get the reduction done. So in our hospital, the protocol states that you can't do a reduction unless you have a bed for the patient to go to the ward. So that already precludes you with timing. So if you have a bed, then you can perform the reduction. Then you need to walk around that hospital and look for weights, ropes, cones. That can take you up to 2 hours. So there's a lot of ground to be covered before you can start the reduction. And when you start the reduction, it's variant on how controlled the situation is, how the patient does, and there's various factors that can delay the reduction. So this is another example. So they also have a bed that's adjusted with the capability of putting an arm up with a pulley and some weights that they hang down. And what I want to illustrate here is that this guy and that guy are all looking at the weight that's being adjusted, and that guy's hands are on the weights to pick it up. So when you pick that weight up, the spasm that you overcame on the neck muscles goes back. So you're starting a few steps back, and you're potentially creating another injury because you reverse the dislocation and dislocate it again before you reduce it again. And you can see the cushion is moving because you're putting this whole patient up on the bed towards the head. So it's sliding off the mattress now. And so I had the same issues in the hospital, and I had struggled to reduce these patients. And I think the day when the rope broke and the 30 kilograms fell on my foot, I decided, well, I need to make a plan. So I went home and I drew this plan and trying to estimate where the central rotation is, what can I do to get this a closed loop system with no loose elements to save that amount of time, so that you can get the patient on the table, do the reduction with no delay. And then I went and I built this bed in my garage. So This is a sheep scale. It's connected to a ringworm. The patient's head is there. He's belted down with the safety belts. And at the bottom there is the old Land Rover jack with an arm that pushes up into flexion extension across this bearing. That's a universal bearing. So that gives you accurate readings in kilograms. It can give you flexion extension to dislodge the facets. And it keeps the patient safe on the bed, and it doesn't move anywhere. It's a closed loop. You don't need ropes. You only need a set of cones. Cones are connected to the sheep scale by 2 metal shackles. So we introduced this bed, and we'll get to that later on how the bed fared in terms of reduction. But doing this, we had to look at the physics of cervical reduction. Now, traditionally it's done inline, which means like those pictures I showed you before, the patient's lying on the bed and you just do horizontal traction. And so with these locked facets, it does make sense that you need to dislodge them before they hook over back to where they should be. And a lot of studies were done around, or actually reports came forth that patients were paralyzed after doing a closed reduction. And the reason is that there was a disc that was behind the vertebral body and that pushed against the cord when they did the reduction. There was large reviews done on this with the emphasis on closed reduction. And the majority of those reviews say that the risk of disc injury is less than 1%, which means that it's all the benefit of the patient and very little risk to do a closed reduction. And the reason why closed reduction is, I'm going to say, more accurate than the MRI is that the closed reduction is a dynamic process with a patient that's awake with a GCS of 15 out of 15, and he can immediately tell you if there's change in sensation or tingling in his fingers while you're performing the reduction. Whereas the MRI is a static entity. It only shows what's there. It doesn't show what happens when you move it. So going back to the drawing board, I think the second thing about acute reduction is you want to prevent secondary injury. So secondary injury happens due to edema, ischemia, and that can spread up and down the cord. And that is what you're trying to prevent by doing an acute reduction. You're trying to reconstitute the diameter of the spinal canal and giving it breathing space, if I can put it that way. So if you have 2 vectors, one horizontal and one vertical, or forces rather, they result in a vector. Now, to create that vector, you need both flexion and distraction at the same time, but controlled. If you do that, my theory in doing this was that you dislodge the vertebral body from that injured disc. And you're actually not pushing against the disc, but you're pulling over the disc and relocating the facets. So we looked at all the spinal reductions we performed from 2008 to 2014 using our traditional method. And as I recall earlier, the success rate was 73%. And a lot of the morale around the surgeons that had to perform the reduction, if you mentioned that you need to do a closed reduction today, their face drops because they know what that entails. After introduction of the new table, there was I would say actually a jubilation when the cervical reduction was announced, because the table made it so much easier. Everybody was enthusiastic about it. It takes 2 hours to get everything done, from getting the bed from the locked up facility to down, get the patient over, do the reduction and done. Whereas before it took a whole day. So we introduced this table and we did a pilot study of 14 patients, and we had a 100% success rate. And in that time with those 14 patients, none of them deteriorated neurologically. They all either stayed the same or did better. And then they were placed in maintenance traction in the ward and awaited an available theatre for surgery. In that time when they waited, their neurology either recovered to a few grades better or they stayed the same, but they never deteriorated. So this is an example of a patient lying supine, and you can see he's got a dislocated bifacet. So the first thing that we do is we put some flexion on the neck. You can see the direction has changed already. And so you increase the weight. And as you increase the weight, you can see that the facets are now unlocking and starting to perch on the other facets below them. And then they reduce. And then you put them back into extension. And you reduce the traction to end-lock the normal anatomy of the spine. So we've worked over 4 years to get to this product to do the spinal reductions with. So it's really simple in the sense that that's an arm that rotates with a gearbox ratio of 1 to 265 connected to a load cell. So the load cell gives feedback to this panel that shows you per kilogram what your tension is. So you can control the tension very slowly, both ways. And this arm gives you flexion extension of that headpiece. So the head is placed on that. That can be adjusted up and down. These shoulder supports has 2 holes, so they just pull out so that you can put the patient on the bed, you put the shoulders in, and the straps are merely for transport if you have to transport a patient from the trauma unit to the X-ray department to do the reduction if you don't have the availability of X-rays in your trauma department. So that the patient stays on the bed, don't fall off, the arms don't hang down the bed. So the belts sort of help to get the patient stable on the bed. We introduced this, and up to now we have 64 patients that we reduced on this bed. And they all came from those injury mechanisms. And as usual, and in according to literature, the most injured levels are C4 to C7. The weight we used was 29 kilograms on average, and the time we took to reduce them was 39 minutes. Now, you can see, if you look at this, some of them took just over 20 minutes, which is quite quick. Put the patient on the table, you start flexion, you put a little bit of traction on 15 kilograms, oh, they reduce. Put them back. Some were a little more difficult because you get these guys, big rugby players, thick necks, difficult, lots of muscles to get over that spasm that you need to overcome. And we've noticed with the older bed, because it doesn't have a load cell to record what we're doing, it took about 15 kilograms of traction to overcome the spasm before you actually start dislodging the facets. And that's quite a lot. That's something I learned from doing this research. So those that failed, they either failed because they reported neurological change, and then we stop immediately, and that patient is deemed getting urgent MRI. Or the cones pull out, and that is a result of poor cone quality or poor cone application. And none of these patients deteriorated as a result of the reductions, and they had a safe surgical procedure afterwards. So I think of all the slides, I think this is the most important slide. So the ASIA score is the American Spinal Injury Assessment Score that quantifies the dermatome and myotome function into a level of function. So if you're a D or a E, you are a functional individual. You'll be able to go back into the community. You'll be able to do what you sort of did before if you're a D, and completely when you're an E. So the idea is to get past C. Now in this graph you can see that one patient over there and 4 patients over there, when we reduced them, went to an E. So they came in as Asia B, non-functional. We reduced them and they walked out of hospital. If you're an A, you're bound to stay in A, because A's are generally higher velocity, more severe injuries. They don't recover. But from a B, C, they do recover. They have potential to recover. And timing of these reductions is the issue. The quicker you do it, the better the outcome. Going back to the Constitutional Court ruling, Dennis Newton did a study where he looked specifically at rugby players, and those that were reduced within 4 hours of injury made a complete recovery. Those were reduced after 4 hours, had persistent neurology. And the courts used that article to base their findings on, to find the government negligent of giving treatment for a reduction in that patient. So, as I mentioned before, time equals cord, and you're trying to prevent secondary injury at all costs. And in peripheral areas where there's no surgical treatment for cervical spines, I think this is important because there's a lack of expertise, but it's very easy to do a reduction. And it's easier if you have a closed system that doesn't have a whole host of loose components that you need to remember. What do I need to get now? Where do I need to get this? What do I need to do next? If it's all in a closed system and you only do these once or twice a year, it's easier to remember, it's more reproducible, and it's easy to teach someone to use this. If you travel long distance with a dislocated neck, it's a problem. If you go through a bump or a pothole, you're putting that patient at risk of getting a spinal cord injury that he might have not had with a dislocation before, and putting more severe secondary injury on that spinal cord. There's a huge cost implication, and we'll go into that just now. And we're doing this all to get the patient in a better prognostic state in the end of the injury. So, Mr. Dillon did a study in Australia where he compared the South Africa situation with Australia. Now, South Africa fits into Australia, just Western Australia, almost 3 times. So I think the problem in Western Australia is a lot bigger than in South Africa. Because in South Africa, we've got 3 centres that does the closed reductions. Johannesburg do them, but not as dedicated as we do them. And Durban also does them as they have equipment to do that. Cape Town's got 2 centres, which is UCT and Tygerberg, that does them. Patients still have to travel quite a long distance from the Eastern Cape and all that. And the problem in South Africa is that there's no infrastructure. If a patient gets injured, the ambulance needs to be ordered. It takes them a day to get there. Our average review was that patients were delayed 28 hours before they received a reduction. And that's before we started this intervention. And the same with Mr. Dillon's paper, reported an average time of 22 hours coming from the rural areas. So this is the paper that they published doing this, and they've also proven, and they've had the same stats, that those coming from suburban areas within a certain time frame, they walked out of hospital when they were Asia B and C. But those coming from far away rural, they never recovered. They stayed the neurological state that they presented in. And so, from this, for each lifetime cost per quadriplegic, it cost the government in Australia $9.5 million. And in this article, it also mentions that, which I mentioned before, that a reduced and immobilized facet joint has better stability and would be safer to transfer. And it does make sense. If you have a dislocated spine, it's unstable. You're going to juggle on that cord like a piece of rope. And you don't want to do that. And I think I've mentioned all this before. The real thing that's lurking on the horizon is the fact that you just need one patient to start a lawsuit about this. And I think it's important to act before it's too late. So everyone will probably ask, what is the cost of a bed? And the bed is $45,000. If you look at that, I mean, it is reasonably expensive. There is an available bed in New Zealand that does the same thing, but that's $250,000, if I'm not mistaken, and that's what I've heard. And that brings me back to a question that everyone wants to know is, why is map driving important? Now, this is probably the most interesting recent article about map driving. It's got a lot of detail on it. And on this article, it actually gives you what happens in different maps of pressure to the neurology in different patients. And they actually specify between 5 and 7 days, and after 7 days, there were no improvement after that. So if you do your map driving for between 5 and 7 days, that's the optimal chance that you're giving the patient. And they actually specify higher maps than we require. We are looking for a map of 80. They actually pushed for 85, 90, and in some patients higher. So Mr. Dillon did a review in RPH where they looked at 100 patients. They excluded dislocations and they excluded the time frame in the acute phase, 24 hours, to eliminate spinal shock. Those patients that were 50 years and older didn't show any improvement. Of the patients that were 50 years and younger, 17 of them all had map driving, and they all were withheld low molecular weight heparin initially. 11 of those patients improved to a functional level, coming in as an Asia A, B, and C. And this actually correlates to other studies, that if you have a spinal cord injury and you do map driving in the younger population patients, they do have improved prognosis. And that's why we are adamant in getting map driving in spinal cord injuries. Another question is, spinal cord injuries are more at risk of VT and PE, and we all know that. This recommendation in Spinal Cord Medicine journal sums it up in this as, it makes it real simple just to look at that. And if you have a high bleeding risk, you wouldn't start that. You would use compression until the bleeding risk is resolved and there is no risk anymore, and then you can start that. Most articles actually advocate a combination, compression and low molecular weight. 80% of DVTs occur within the first 2 weeks of the injury. And 37% of postmortems actually showed an acute mortality associated with spinal cord injury and having pulmonary emboli. So the risk of PE DVT is in the first 2 weeks of injury. That's called the acute phase. And they actually recommend, well, I'll mention the recommendations at the end, but spinal cord injuries are at high risk of DVT and PE. So patients with a spinal cord injury have a odds ratio of 8.6 compared to a general trauma patient. And those that are at risk are paraplegia, those that come in with Asia A scores, associated lower limb fractures and pelvic fractures are at higher risk, and those that have the history of previous DVTs and PEs or some underlying clotting factor dysfunction. Age is very non-specific, but we saw in our review that maybe 50 is the cutoff for will they actually improve or not, and we know that older patients are more at risk of VTE and PE than younger patients. So that brings the next question, so what do you give? And just to sum this up, a lot of studies have been done, and low molecular weight heparin is the drug to give. And the recommendation is if you don't have that available, then you can use unfractionated heparin. And they actually indicate that you need to use this for a total of 8 weeks in the rehab phase of the patient before you stop any anticoagulants for prophylactic prevention of PEs and DVTs. So when do you start giving this? This is a large study that was conducted in 2009. And basically, all literature from that forward agrees with this, that you can start this low molecular weight heparin within 72 hours of an injury. You can withhold it 6 hours prior to surgery, and you can restart it 24 hours post-surgery. Should be safe. Unless there's other risks of bleeding that needs to be evaluated. So in that article, the main recommendations for this is mechanical prophylaxis, use low molecular weight heparin, daily assessment to the risk of bleeding so that you can start the low molecular weight earlier if you can. They are against low dose or adjusted dose unfractionated heparin. Vitamin K antagonist is not in the acute phase injury. You can start that in the rehabilitation phase of the patient. Oral anticoagulants needs to be started also in the rehabilitation phase, at least for 8 weeks following a spinal cord injury. They don't recommend IVC as a prophylactic entity. They only, in this study, said that if there was proven previous DVTs, previous PEs with high risk other injuries, then a consult to surgery is recommended for an IVC. And they do not advocate doing Doppler ultrasounds as a prophylactic measure. And in our unit, we do that in those patients that had delayed low molecular weight heparin started on them, just to make sure that there's nothing before we introduce the drug. So for the high injury patients, the ICU patients, those with associated lower limb pelvic injuries, that group of patients. Then there was a report about spinal cooling a few years back by an American who reported he did spinal cooling for a American football player, but there were no results after that, and that hasn't been proven to surface more results of spinal cooling being effective. So to sum it all up, I think early intervention is crucial for spinal cord injuries, especially in the dislocated population. In my study, if you take the numbers, we saved 5 patients, equates to $47 million that you save the government by getting a guy from being almost a quadriplegic to functional in society. MAP driving is important because it improves patients' outcome. Steroids is a controversial issue. Some case reports indicate that steroids does make a difference, others are against it. The majority of reviews say that steroids does not make any difference, and cold therapy shows no results. Thank you.
Thank you very much, Dylan. We'll take questions from the audience.
I have a microphone.
Yes, please speak into the microphone. If you don't get to speak into the microphone, we'll repeat the question for everyone to hear while somebody is thinking about it. The 6 or so patients in your study who had no neurological recovery, do you know if that was because they took a long time to reach you for reduction?
That's a good question. It's variable in the sense that most Asia A patients sustained a higher velocity of injury, so the core damage is more significant.
No, these were Asia Bs and Cs. I think there was.
Yeah, there were 16 Asia A's in that graph that I showed. Most of them had higher velocity injuries, more severe spinal cord injuries, and it's often difficult to ascertain what the Asia level is before the patient gets to you, whether they were falling from a ladder or rugby injury or MVA, because we had MVAs who came in as an Asia B and then recovered, and we had Asia Bs in an MVA that came in that resulted deteriorating without any dislocation to an A. So it's kind of difficult to say, but what we know is that early intervention does make a difference.
Great talk, thanks. I'm John, I'm a CU consultant. How do you think we're doing here at achieving these lofty aims? You know, I think early intervention and map targets and early DVT intervention is standard of care, or should be the standard of care. I guess I would struggle to think of a patient that we're putting on lower electro weight heparin within 72 hours in this institution in 10 years of working here. So that certainly seems like that's an area we could improve in. And I suppose another thing, we see quite a lot of surgical delays in some of our spinal injury patients here, which stuff like that, sleep source management and things like that. But do you think we should be making strides to getting these patients operated on earlier here? I can think of a patient put upstairs at the moment who's over a week into ICU stay without an operation, lots of delays related to figures and things like that. Do you think we're trying hard enough to get these people operated on earlier? Do you think we should change our focus?
That's a good question. I guess that's going to determine what the capacity is of the institution. And there surely must be a drive to get these patients stabilized as quick as possible to give them the best outcome. From a dislocation point of view, Mr. Dillon has been doing the reductions, and he has had 5 patients that were Asia B in Royal Perth that walked out as Asia E. So closed reduction does work, because to get a theatre ready for a ACDF on a patient, if you get it done within 4 hours, I think you're very good. The reason why I'm mentioning 4 hours is that's the timeline we have in South Africa. There's no way you can get a theatre ready in 4 hours in South Africa for ACDF. But you can do a reduction in 20 minutes. And then you can wait for theatre as long as you want, because the cord is reconstituted in the diameter, and the edema and the surrounding injury is less severe. And I think that's the driving behind this. It's more for people coming from far away, where there's no availability of a spinal surgeon or a service dealing with spinal cord injury. And the map driving is something that we can teach the peripheries to adopt. And they can start early on looking at blood pressures, just maintaining spinal cord perfusion. Because a lot of times when the juniors look at spinal cord injuries, they don't put that much emphasis on blood pressure. They look at the patient in general, but they don't put emphasis on getting the cord perfused. Excuse me, because I don't think they get taught that as a crucial area of spinal cord injury. And even in brain injuries, I think that's, they go hand in hand.
Do you think map control makes sense, without some form of intervention for decompression? Because again, I guess we see quite a lot of that with all of our patients who are doing 7 days of blood pressure control on without, an ACTF or a reduction in those patients. It's hard to marry that idea that we're on the one hand we're trying to prevent secondary injury with blood pressure control, but we're not doing the potential prevention of releasing that cord, making that dealing with that cord.
It's a good question. So I don't know, and I'm not aware of any studies that compared the period of patient that's still subluxed or dislocated with the one that's reduced before they go to surgery, and whether they had low molecular weight heparin, whether they had map driving or not. So I don't recall any studies giving figures on that. But I do think that we need to make every effort in giving the patient the best prognosis. Whether you drive the map not knowing what's going to happen, if you didn't do it, you don't give some benefit. But if you did do it and it is a benefit, that's great. I think, yeah.
I think if I'm not mistaken, Andy's question, I think we're clear that dislocations are treated acutely. What about all the other spinal injuries, the large proportion of spinal dislocations that we see here? These are joint fractures, etc., etc. How important is the same principle that you've just espoused for dislocations in the large group of other spinal injuries that we see?
So that is exactly what Mr. Dillon looked at. He excluded dislocations and the first 24 hours of spinal shock. And they looked at all the patients with Asia A, B, and C classification when they came in. So they were like a burst fracture with cord that was injured, or a central cord syndrome, or anterior cord syndrome, those patients. When they were 50 years and older, regardless of what you did, they didn't improve from that Asia grading. When they were 50 years and younger, 17 of those patients received the MAP treatment, and 11 of those recovered significantly. And I think, that's 25% of improved prognosis on a small group of patients. If you did that in 1,000 and you extrapolate that, that's a lot of patients that you potentially save. So, does that answer the question?
I think I strongly agree with the ethos. I'm just not sure that we're pragmatic or we're delivering on that. Certainly the cases where we don't deliver on that stand out in the mind, and whether that same prioritisation of surgical release is given, I'm not sure. But yeah.
To be fair to Delwyn, certainly since February.
Yeah. I'm certainly not blaming him for the long health culture.
I saw these spinal consultants would turn up today.
There is one here. There is.
Oh, sorry. Oh, in fact, it's a good opportunity to introduce Mr. Alta, one of the newest spinals. Again, he's
I'm also video.
He's again, because Delma, could you just introduce yourself when you speak?
Sure, I'll talk about it in another 10 seconds there. So, Mr. Dillon did the study, and it took 22 hours on average to get people to tertiary spinal cord injury, and we sent 45,000 for a bed versus 9 million for a lifetime quadriplegia. How do we overcome the geographical challenges of WA? Do we need to be more hub and spoke in teaching these peripheral centres? As you've already mentioned, to do map driving. Is it on the horizon that we teach them to do close reductions? If that's the only chance of improving the outcome of these patients.
That is a terrific question, yes. The answer to that is yes. The plan is, both from myself and Mr. Dillon, in a South African and Australian point of view, that the young guys coming up, the registrars, the junior doctors or senior medical officers, RMOs, they need to be taught how to perform a closed reduction. And with the availability of telehealth, WhatsApp video call, you can assist someone in the periphery when they have the equipment to perform this reduction quite easily. It doesn't take a lot of training. It's easy to teach someone to use this table to do this reduction. And I think our main focus is we're trying to get the equipment available, because you can't teach someone if there's nothing to teach them on. And then starting to educate the younger guys and the guys out there to perform these. And we're always available to help. We need to streamline the modalities that we've got available to assist in doing these reductions.
Could I just add a bit to that story? And just looking at Maxine at the back, David's been on at least a 3-year mission to get hold of one of these tables, but also put Gatherwell's tongues in all. Some of the regional sites, we've agreed finally that we should at least pick 3, and we went to East Metro for funding, and they said no, WACS should fund it, and WACS said we've got other priorities apart from spine, so we're trying to get some money to do this. Given that ETS is just upstairs, we thought it'd be perfect. There are no registrars in regional sites apart from Bunbury. That it would have to be someone sitting upstairs and directing someone in wherever Jenny Vance works in Karratha on how to do one of these. It may not happen more than once a year. It's, from WAC's point of view, it's just a lot of money for them to spend. So, Jenny, question?
Yes, I think Siddharth might have partially answered my question. So I'm Jenny, I'm one of the ED physicians here, but I do fly out to Karratha, which I'm not sure if you're sure of geography, but it's about 1,900 up north. And certainly it would be absolutely amazing to be able to do something to help these injuries out there, because you feel very helpless when something like this comes in. And my question was, had anything been done as yet with WACS to try and start that pathway of enabling this something to happen out of the education?
Yeah. So we thought we'll start with 3 sites, and there were Esperance, WACS and Esperance. What were the other 2, Maxine? Albany and one other, but not Karratha. So the problem is, can it be done without the special table?
Well, the answer is yes, it does work, but it comes at the price of a lot of risk on loose elements. If you do this only once or twice a year, I think you're going to stand there and wonder, what are all the pieces I need to do this, and where am I going to find this? Because using this infrequently, all that stuff gets used for others, hanging up a piece of thing on a wall, or the rope gets lost, the weights get lost because they are door stoppers. So in that sense, I think the table is essential because it's reproducible. It's one thing, it's got everything on it. The only thing you need is cones. And a cones is a sterile thing that comes out of an autoclave. So that's managed by the surgical entities or the hospital manager. The other stuff is non-relevant anymore if you have a table. But you certainly can do a reduction without the table. Even if you have to start at that point and facilitating those areas with a rope, with weights, with a pulley and a wheel. The issue around that, as I showed in that picture, is when you need more flexion and you are already at 25, 30 kilograms of weight, you have to now take that thing in your hand, pick it up while you're unscrewing this with the patient connected. There's no control on that. It can just slam down, injure your hand, patient gets injured. I mean, it's really an uncontrolled system. And so the bed makes everything so much more controlled and less stressful for the guy that does the reduction. In my own experience, I'd never go back to the traditional method. I'd probably do it if it was the only thing that's there, because I know how to work with it and how to do it. Because I've done more than 30 of them. So I think, to answer your question, yes, but I think the bed is essential. If you want to train junior guys and guys that performs this procedure infrequently, you need a bed.
But a more realistic thing would be to start driving the blood pressure to a map of, did you say 80 or 80? 80. There's some discussion about the map process. ICUs now keeping patients in for a while, just keeping their map up.
The target we're often given by the spinal team is, as you said, 80, which, if not, the numbers themselves may not be, exact, but certainly disparate to a lot of the studies. I just wonder where does that lower target culturally come from here, compared to the fact that 85 to 90 is nearly always the target. Every study I've ever read on it has been 85 to 90.
I don't know where 80 comes
from. I generally go to 85.
I always thought it was 85 as well. But when I got here, it was 80, maybe Veronica.
I think some of the initial studies did mention and did have 80, and some of the studies from Vancouver had 80. So I did a fellowship in Vancouver, and they had 80 as a map driver as well. So we're not the only ones. But I agree, there are a lot of studies that mention 85, but there are the big centres that follow 80, because I think it's a balance between, the downsides of having inotropes and the negative effects of that. If you go 85, 90, that can have reduced complications from inotropes as well. So it's like striking the balance.
One of those studies showed, so I think it was at every period of relative hypotension where the map dropped below, I can't remember what the target was, maybe 70 or something. It was hard now, our baseline 65, and they suggested that every period longer than 5 minutes they gave a worsening. And I wonder whether that was the drive to push those numbers up to try and prevent those temporary drops that maybe we wouldn't see as hugely significant, but seem like they're having significant as well.
So just going to ask how long for?
So general literature advocates between 5 and 7 days. And after 7 days, there's no point in trying to drive the map because there's no improved prognosis.
Sure.
Hi, Joanne. I just want to say actually the table is great because for a person who has reduced many fractures over the last 18 years, having 30 kilos hanging on the end of someone's head while you're waiting hours and hours for them to reduce, where obviously yours are reducing, within 30 minutes, is great because when you've got someone that's vomiting and you try to turn them and you've got 30 kilos hanging off the end of their head, you as a nurse have to manually turn them. That is really heavy and it's really you're at a high risk for doing yourself some injuries. So personally, I think the table is great, and you're right, trying to set up a bottom frame with traction, with ropes, with 2 ropes, and fit 30 kilos in one water weight bag, is quite labour intensive. And I think 45,000 is quite a standard. a safety and overall safety perspective. Just following on from the map driving, and that's a very interesting paper. I'm sorry, I'm sure not about the use in particularly central cord syndrome in patients above the age of 50. And because you talked about that paper of Dave Dillon's, which is very interesting, that talks about perhaps is there a flip side, we shouldn't be map driving in those patients if there's no guaranteed improvement in outcome with all the problems that are associated with it, and are we simply extrapolating the use of map driving from significant cord injury to things like central cord syndrome and Silver's?
That's a very good question. And I think the answer would probably lie in doing a study looking at that, because I don't think studies look at the side effects that particularly in map driving. I think they're focusing more on the improved prognosis of the patient rather than what happens if the map does the opposite. And how do you quantify that? How do you see that? I don't know if Iran saw any studies that looked at this, but I can't recall any definite study that said if you drive the map, these are the side effects or negative results in patients that's older than 50 or whatever the age may be. I can't answer you particularly on that question. Maybe Iran has an answer.
You guys comment? I see it from an ICU point of view, yes. Driving the map.
I think there is actually
there's multiple studies showing some of these side effects there.
There was one that showed a rate of higher arrhythmia, I think, with catecholamiine used to drive map above 85. And I can't remember the numbers, but I'm pretty sure that it's a pretty known side effect if you drive it up. I think the question is sometimes what agent's been used. A lot of those studies from America where they use dopamine a lot more, and there's certainly a higher rate of arrhythmia with dopamine use, and that's been reported when we've driven maps up for other conditions as well as spinal injury as well. I can't specifically say that what we do pragmatically, which is noradrenaline use, that I can quite any figures, but you'd assume that
I mean, there's a study done in Vancouver comparing dopamine and
yeah, that's what I'm thinking of, yeah.
And then with dopamine, lots of patients became intolerant of it, and also high risk of arrhythmia, so they just stopped doing dopamine completely and started using norepinephrine.
You'll definitely see some arrhythmias with no other results. It's something like that. So we know in comparison with the right to drive blood pressure receptors compared to taking vasopressin, where you're not having that catecholamiine, you don't get less arrhythmias with vasopressin.
And I guess the other issue is the pathophysiological process of central cord syndrome. This is a transplant, significant spinal shock transection, those other injuries, and should we be separating them out, or should we just have them all in one bag of cord injuries? Certainly from an emergency perspective, if there's out there.
I think central cord should be treated as a cord injury as well. And I was recently at the Spinal Australia meeting, and Bailey was there, who's done a lot of work on these withdrawals, a lot of work, and they're just recently working on a study, and he was saying that they should be grouped together, and they're even from their point of view, they're even saying that they should, because central cord syndrome has always been a controversy even in the literature. Should we operate on them early? Is it within 24 hours? Other people say wait a couple of weeks to see if they improve. Depends how severe they are. Clearly, if there's an instability or a disc disruption, then there's an argument to stabilize and decompress. The question is, do we treat them like the rest of cord injuries? Do we decompress them early? Other people wait for 6 weeks to see if they improve, because generally they do better than other cord injuries if they're not severe. But Bailey was saying that they, from their point of view, are going more towards a more aggressive management, or even surgically, which isn't a global perspective, but that's more from the North American models. They're generally tending to actually even operate in 24 hours, but they would treat them like any other spinal cord injuries. I think they should be, from that point of view, in terms of how we surgically manage them. I think we need to get a consensus on that as well, which we haven't got.
Can I just ask the ED physicians who do work in regional centres like Jenny and Albany does, having heard the evidence today and possibly reading your own literature, how would you manage a patient with a spinal cord injury, in terms of the map, never mind the mechanical stuff, is that going to be easy for you to just set up a farm course call and transport them without having to go in central lines, etc.? Jenny, then pass the mic to them, and then Jenny.
No, I was just going to say, it has been standard of care to manage MAPS early, certainly significant spinal wound, it's very simple, straightforward. I mean, the problem, of course, is our eyes, people sort of dilating with the thought of how on earth, from a West Australian point of view, that you get patients within 4 hours to somewhere that can produce it, even with beds, like 3 beds, it's still, logistically, that could be a whole different
Jenny. Yeah, so just last night a plane broke down in Geraldton and we didn't get the patient for 12 hours.
I think it's very dependent where you work. Certainly a lot of the country places like Karratha, we don't have a high dependency unit. So trying to run any inotropes and to get the nursing support behind that is really, really, really tricky. And that is, I think it depends very much geographically where you are in that high dependency unit situation. So whilst the doctors are prepared to do it, the nurses won't. You're up there with the nurse managers as to what infusions you can run.
Well, maybe that's something the State Trauma Committee can take up later this morning, Maxine and Heidi, when you come to the committee meeting. Perhaps that's one thing we could do in the periphery, start driving the map up. Are there any other questions from the floor? No? Any final comment you want to make? No? No? Well, thank you very much for really good expose of a few of the interesting things. And we will look forward to working with you with a few new protocols. Thanks very much.